Welcome, everyone, to our second cardiovascular disease moment of the day. My name is Eva. I head up communication patient advocacy for international cardio-renal metabolic at Novartis. It's so great to see so many of you here. I have a question. Who was here this morning in the first session with Patrick? The speakers? You? Okay, good. Okay. So this morning, we set the scene, set the stage, and we talked about cardiovascular disease as a whole. Number one killer, affecting still 20 million of lives of people every year, and increasing every year. So when we were thinking of this session, we had several options in mind, and we obsessed on the title, Impact Session. And we can hear from our co-panelists, there's so many talks and intentions, and we're going to do this. So we're going to try something different. And this is my first WEF, so I'm going to need all of you to help me here. We're going to try to tackle one issue in cardiovascular disease, and we're going to try to co-create an idea of what a value-based partnership could be, a co-pilot, create a solution, and the goal would be to roll it out in 26. So we have AI specialists, we have neuroeconomists and behavior scientists, we have the World Heart Federation, and we have you guys. And the idea is to say, okay, we don't want to boil the ocean, but let's tackle one thing. We know behavior messaging are not enough. All of us know the good and the bad cholesterol. 80% of cardiovascular disease are preventable, and yet the numbers keep increasing. And we keep improving the medicine and the science, etc. So I think, it's time to try to change paradigm and do things different. So again, because we don't want and we can't boil the ocean, I want today that together we focus on failure after acute events, meaning a stroke or a heart attack. Post-event care is a critical example of the overall system failure. Patients luckily survive the event, and then, in a nutshell, disappear in fragmented pathways. So the question for this session and for all of us is, it's not the medicine, but how can we follow, reassess, and optimize? Where do we lose them? How can we not lose them? How can we prevent that a second event happens? So we're going to briefly brainstorm ways of how we can tackle what we call the LDLC, so bad cholesterol blind spot, and try to align on this actionable value-based partnership that I was mentioning. We'll be focusing on outcomes and system efficiency. Again, the goal is that we meet again, same time, same place next year. We look at what we've done. So I'm making ourselves accountable here. And for that, we have three amazing panelists. Each of them will talk about why they're here, their line of work, share their lens. And then we have you as active contributors. Please don't be shy. I'm going outside of my big-time comfort zone here. So I hope you guys do the same. And if you want to share your thoughts on social media, the hashtag is heart to heart. I'm communication, so had to have a hashtag. So without further ado, I'm thrilled to introduce our three panelists, and I'll start by Boriana, CEO of the World Heart Federation. If you want to come in the middle. Yeah, come here. Oops. Here? Yeah, sure.
Oh, wow, okay.
It's you.
Okay.
If you want to introduce yourself.
Yeah, sure. World Heart Federation is the umbrella organization representing the cardiovascular community, not just on scientific societies. In each country you have a National Society of Cardiology, but you also have foundations who advocate for heart health, who are more, let's say, policy and communications and advocacy oriented. We have 200 members from 140 countries, and our goal is very simple, to put cardiovascular health at the top of the agenda agenda of politicians, but also to connect the dots between the different, sometimes disparate parts of the world and different aspects of healthcare, focusing on prevention. From what Eva said, you heard 80% is preventable. So we are basically out there in the business of trying to transfer this 80% preventable into percentage of saved lives. And personally, I come from a journalism background, investigative journalism. So I'm always there to ask the questions, and sometimes they are very uncomfortable questions. But you already took that place because you said, if we have the science and the knowledge, what is wrong there?
Yeah.
So I would say just the failure. There is, of course, a failure in the system. And it's not necessarily, it's in the whole continuum of care and also on prevention. Sometimes it's, I know you will be focusing now more about post-MI, but even before that, and even when that happens, sometimes especially depending on where people live, how much they know, what is the infrastructure, they wouldn't go necessarily even in that case to care. And not to mention that once you're in clinical care, there's a wide variety of guidelines. Sometimes they're not implemented. They're not, sometimes the health system and the cardiologists or the treating physicians are so stretched that they wouldn't necessarily have even the time to consult the latest updated guidelines, et cetera, et cetera. So it's really through all levels of society, and it really shows that, yes, we're advancing, and we heard a lot, and I think this is the place to be. It's like, it's where, politicians and business people meet, but we heard a lot about latest inventions, but at the end of the day, it's also the time and the choice and the options that we have in front of us. It's not just about what is accessible out there, but how do we then make this, this really, really real for people and people from everywhere, not just necessarily the world that most of us represent here.
Yeah, thanks. So that's a great segue, because what I understand is failure so it's not a lack of knowledge, but it's a lack of system ownership. That brings me to Christian Ruff. Professor Christian Ruff is a neuroeconomist. Please introduce yourself. And
Yeah, hi, I'm Christian, I'm a professor here at the University of Zurich. I'm a behavioral scientist and neuroeconomist. What does that mean? I'm interested in how all of us take decisions, how we learn from our experience, what motivates us, and what role actually the other people around us and so forth play in shaping our behavior and our habits. I say neuroeconomist because we study from the perspective of the brain processes, but that's really just because we believe that if we look into the brain, we can find out a bit better what motivates us than if we just ask people. But what really mainly motivates me is that I want to understand really how we can help people take better decisions, how we can help people behave in ways that are beneficial to our own outcomes. And I mean, we heard it in the sessions this morning, and we heard it now from you and so forth. I think on the front of the treatments and the diagnosis and so forth, we're entering an era where it's going to explode. We know a lot already about cardiovascular disease, but there's going to be so many more treatment options and so forth. But at the end of the day, the people who have to seek the treatment and have to administer the treatment, it's people. And the interface between us and the technological world and the health system and so forth, I think that's where there's most of the frictions. So most of the problems we have, I guess, is in people not seeking help, or people seeking help but not getting it, or people getting help but not understanding it and not following it. So my hope is always with our research that we can have an impact, that we can use this research knowledge that we generate to really help people. So I thought that this is really an area where our research may have an impact, and I hope in this session that we can somehow together come up with a good plan where each of us would say, yeah, well, that would help me actually follow treatments.
thank you. And our last panelist, Thomas Clausel, is going to share about yourself and Okin, your AI-driven impressive unicorn. And also, we'd love to know from you, like, if we wanted to make post-MI care gaps visible without moving data, but violating trust, of course, how would that be realistically possible today?
Yeah, so nice to meet you. I'm Thomas Clausel. I'm a physician by training, an entrepreneur. My belief for research in cardiology and in general is that a human cannot drive biology research anymore. It's too complicated for the human mind. And I really believe that there's too many scales, too many modalities. So I believe that we need to create agents, AI scientists that can do the research alone more and more with a super intelligence, which means that it's not like biology is being co-piloted, but it's really replacing actually biology researchers. I believe this is the only way to go to singularity, which is like accelerating productivity, and the only way to make it work. And for that, you need a really great AI, an agent that has a lot of skills, an LLM as a brain, and a lot of data to make it faster and better every day. For cardiology research, I think there's a lot of things to build for secondary care, secondary prevention, new scores, new diagnostic tools, and even new treatments. But for me, this has to be multimodal to capture all the modalities and the ground truths of the biology, which is why people relapse. And we need to get out to something that can understand not only building a score that doesn't make sense, but having something explainable. It's not always explainable in cardiology. Sometimes you predict something great, but you don't know why it works. So the question is, how can we build a multimodal score with an AI agent? Not human-driven score creation, but having little robots that will create its own agents in a very smart way and having implementing it. But I know every year I do this type of talks, and I know Eva has way more energy than others to make it work. But usually you say, I had this like 2 years ago, say we're going to treat glioblastoma, and we haven't really, whatever. So I'm trying to figure out how can we make better decisions and how can we. So I really have a question for you, Christian. Is like why when we take a commitment every year, we don't really commit to it eventually. What is the secret to actually commit to something?
So what you're talking about is this pre-commitment problem, right? So pre-commitment. So problem. I mean, everyone knows New Year's resolutions. They're usually broken by the 15th or 16th of January. Right? So we decide we want to do something when it feels urgent, when there's an emotional state. That's why donations for particular causes always spike when there's something terrible happening, even though if you ask people at any moment of the year, would you give money for this? Yeah, I would, but people do it when they feel like it. Right?
Because it's here.
So I mean, I think we can talk about this when it comes to cardiovascular disease, but if we should talk about how we can keep our commitments, then we have to look back to the ancient Greeks, to Ulysses. Pre-commitment, right? Ulysses knew when they were sailing through this place where there were the sirens who lured people, and he really felt that he wanted to hear them. He said, "Bind me to the mast, bind me to the mast. Whatever I say, don't release me." Right? And that's what he did. So he could hear the sirens. It was horrible for him because he wanted to get out and follow the siren's call, of course, but he didn't, and he didn't die. So pre-commitment, that's something we have to think about. At a moment when I'm not tempted not to do what I actually promised I would do, we kind of have to, in the moment when we really want to do it, come up with mechanisms that's going to ensure that we're actually going to do it.
But you say that it needs to feel the sense of urgency. So cardiovascular, as Patrick said this morning, is silent most of the times, and it's for mostly people that are a certain age. So for example, we have a very young generation. They don't feel the need to work on this. So how can they pre-commit on this?
Yes, so I think we should talk about different things. I mean, I don't know whether we should go into primary prevention or secondary.
Secondary.
So secondary, there is the urge, right? There's an event, something happened, you go into...
But not for yourself or other people, yeah.
No. So I thought we're talking about people who haven't had a cardiac event.
Yes.
And then after, how can we make sure that from then on they keep monitoring?
Yeah.
Right? So here, there is the need or the urge. Problem is it's going to dissipate. It's like a New Year's resolution.
Right.
So we have to make sure that from the level of the system, but also from the level of the individual, at the time when people feel it, when it's like, oh my God, I had this event, I managed to get away, I don't want to die, I don't want to leave my family behind. At that moment, we have to come up with a plan that's crystal clear. What are you going to do, and when are you going to do it, right? Like so, when are you going to measure? What's going to be the target? What are you going to do if the target isn't met, and so forth? And I think we have to help people remember that they have to do this. And there's various possibilities how we can do it, and to be inclusive, as you were saying. Some people, like you know, like we can equip them with wearables and apps and have the machine tell them at all times what to do. But other people who may not like it, we should come up with human solutions, say with some kind of panel or some kind of committee, right? That you could opt in to share your data with, and we're going to call you if you forget, and so forth.
Maybe there's a different way to commit. Less or less technology.
I think so. But we should strike the iron when it's hot. We should help people really come up. We should tell them exactly what the plan is, and we should come up with structures that are going to help people to then not say, well, I'd actually rather go to the cinema today than to go and measure my.
Yeah.
Can I add something to this?
Yes, please.
Just one thing. There was a recent Inspire study that looked at 4,500 patients post-MI. And 1 year after the event, only 1% of them have reached their goals and their risk factor
Only one?
goals and lifestyle goals.
so small.
1%.
Why is it small?
For LDLC, it's 20 to
For
40%.
all of them combined.
Yeah. Within
There's
12
just
months.
1%.
Secondary, right?
Yeah, of course. Yeah.
Yeah.
Basically, can I just add something? It's incredible. I have a friend who is a professor in neurology, and he's the best specialist in intensive rehab, right? And his best marker of actually people getting better when they have a stroke or whatever is actually people that take the commitment to write on a little book. When you actually do write on a little book, people that do that usually are other people. So just committing to actually write your progress, it's actually kind of a pre-commitment, and it's actually the best surrogate marker of outcome. It's crazy.
And actually, so there's yet another mechanism at work here. So we work very much by feedback. We need to want to see results, right? And that's another problem, right? With like all these medication treatments, if we don't measure regularly and we don't see that we're going down and we're staying down, we think we've done it. We think we fixed it. We thought the problem was solved, right? So we should probably come up with some solutions. I mean, I'm personally a fan of digital, but I appreciate that not
No, AI. He says no AI. I won't get money from Novartis, so please.
I think AI may or may not play a role. Again, it depends. It depends. But no. But the point is just that people should really be able to see and track any moment of
progress.
time where they stand. And I mean, if you combine that, that's behavioral economics 101. If you combine that with incentive schemes, you know. So, for example, I mean something. So your health insurer, for example, may give you some contribution to a gym membership, right? For example, right? That's an incentive scheme. So perhaps something like that could be combined here, right? That you could say perhaps people could get every year that they meet this particular goal, right? That they measure and that they meet the goal, they could get some discounts, for example, right? Discounts to gyms or so, right? I think one would have to find partners who say this is good for our incentives too. So if we pair with them, then we motivate people in a gamified environment, so to say. So just always keep track of where they
Outcome-based
stand.
pricing. The more you lose weight, the cheaper you pay or whatever.
Yes.
That's cool.
And now I tell you something that sounds completely crazy. If you do this in a way that people can opt to share this with their friends and to kind of compare and I've kind of met this. This has the strongest effect. It's ridiculous.
Yeah.
It depends which risk factor you take, right? When if it's
Yeah.
obesity, it's difficult to say, hey, I lose like 5 kilos. No, it's true. It depends on which thing you really share.
But even so, right? All these weight loss programs, those are most effective, where people reinforce each other,
By
right?
the community.
Yeah,
By the
community.
I mean, yeah. So number one is you see that everyone does it, so you don't feel singled out. You don't feel I'm sick. The others do something
that's
else.
it.
So there's a community, but also just social reinforcement is one of the strongest things we have.
It's true
right?
even for the ORA rings that you can create a community, and they show that when you create a community and you share your results of your ORA rings with others, you're more efficient.
Yeah.
That's it. Okay.
Okay, guys.
So we have a
Let's go back. Don't.
we have a digital
I know. Okay.
1 to 10%. Secondary care. We have the goal. That's perfect.
Okay, we can go and have coffee now.
And maybe AI can okay. I don't think it's needed. Okay.
No AI? Okay, no money. So okay, we agree. We're talking about LDLC blind spot, post-MI. Okay, as we said, 20-40% of people, well, 1% in general, but for LDL is they don't achieve their. Yeah, sorry, myocardial infarction. So, stroke, heart attack. Yeah. I'm not scientist, but I think heart attack and stroke is the good one. So what we're looking for, and that's when you guys can jump in the conversation, we're looking to create a pilot that could, that's ideas, identify who is not being reassessed, where the system fail, how can we enable pathway redesign, okay? So the question to you is first, is that the right idea, like the right thing we try to fix? And also, I'm a huge fan of value-based partnerships. So it means that we want to together improve patient outcomes, post-MI, and we're all of us doing different things, bringing our own solution to the table, okay? So that means that you will bring your perspective from your organization and the patient. You're here representing also all the patient advocacy groups we work with. So how do you help us improve their job in convincing patients in helping convincing? Because we know campaigns don't work, as I said at the beginning. And then how do you help with your AI tools and the tools?
I genuinely don't think it's needed. So I think sometimes AI is not needed. Sometimes process and digital tools are needed. It's more about the digital tools and some type of community building.
Community building, it's all, yeah, I think that's
has to
it.
be
Yeah.
around this.
Okay.
Yeah.
Not around AI.
Yeah, and patients have to be involved from the start, obviously.
If we work with the heart center of Zurich or Lucerne, for instance, keep it here as a pilot, what do you think would be a nice pilot between all of us and more? And what would be the outcome that you could imagine?
Try to predict before they arrive who is going to be the 1% and who is going to be the 99%. And if you can predict why are we predicting well and try to understand this and put some digital, very simple tool that help us help the 99% getting better. But it's interesting to cluster them.
So prediction is one thing, but again, you fall in the problem that you need a lot of data.
Yeah,
I mean, I'm totally not.
But cardiovascular, you have that, right?
So something that would be, in my eyes, a lot easier to roll out, is this idea of coming up with a very clear plan to give people what it is that they're meant to do, when and where and how, and give them some reminders of sorts, right? And perhaps you can do it for half of the people you do it, half the people you don't do it, and then after that 1 year, you actually compare rates, right? You compare how many people went and measured, where are they, right? I mean, there also is this option of, or this question of treatment escalation when it's needed, right?
Yeah.
You know, like some people, they get statins, but perhaps not the right amount. So like, how do you decide to actually get more and so forth? But I mean, I would do something in addition to all of the predictions. I do something simple.
Yeah, but so building on a side discussion we had before this, where you talked about the optimism bias and the fact that people don't do, if you do such a solution and let people, even though, what is going to make them actually go to the next appointment or write down in their book there by themselves?
So basically, I think if you give them this information and roll it out for them at exactly that moment when they feel there's an urge to do it, right? And they, in a way, opt into a system where they're just going to get these reminders and so forth. And you point it out to them that if they reach these target levels, right? And only they need to know it, right? No one else needs to know it. That reduces their risk of getting a further thing by 21 or 25%. You're focusing on the positives. You're focusing on the goal that they're trying to meet. You're not telling them if you don't do it, if you don't meet your goal, you're going to die. Right?
That's fear mongering.
So I don't think that this is against the optimism bias.
And what about so we have very young people here. Yeah. The AGI natives, they were born pretty much with AGI, pretty much. And so how can we make them, they will be the smartest about anything AI related or digital related. And how can we make them interested by this topic and make them feel it's also something emotional for them, you know, when you're very young age and you're not touched by this or, you know.
Should we ask them?
How can you try? Yeah, I don't know. I mean, you would say, I mean, you should like cardiovascular disease, right? I mean, you would be right.
But basically, what do you think? Like, you think this is something for older people, right?
For now.
Yeah.
Good education, but what's your, you know? So, you tell me we need emotion, or how can we create this emotional link?
I mean, we need emotion and information. I mean, I think if you guys don't know that there's genetic risk factors, and if you knew them, you could preventatively, you know, reduce the risk of many things.
Have to wrap up. So thank you all of you being here.